Thank you so much, Tanya. Implicit bias is one element that reinforces and compounds social determinants of health. I'm Brandis Wallace, the Community Engagement and Education Coordinator for the Michigan Health Council. Behind me is Crystal Ray Community Center. This community center is a lifeline to many people who use its services, which include a health center, vaccination clinic, food kitchen, food pantry, and financial empowerment services. We hope you'll take a look at the virtual exhibit hall, where you'll find more information on how to get involved in your community, no matter where you are. Our next speaker is Dr. Susan Swider. Susan is a professor in the Department of Community, Systems, and Mental Health Nursing at Rush University in Chicago. She is a fellow of the American Academy of Nursing and the Institute of Medicine in Chicago. In 2016, she was appointed to serve on the Community Preventive Services Task Force of the Centers for Disease Control and Prevention. Please welcome Susan Swider.
Good morning. I'm Susan Swider. I'm a professor in the College of Nursing at Rush University in Chicago, Illinois. And I'm here to talk today a little bit about health equity and how it relates to engaging with patients and communities. So what we're going to talk about today is a little bit about the concept of community engagement, but we're also going to talk about patient engagement. What is it about engaging with the people that we work with that really is important in helping to achieve health equity? So there's some learning objectives on the screen in front of you. We hope to go through that today. And I'm going to illustrate with some of the work I've done in this area over the last, I don't even want to say how long, 30 years. I want to start with a background, and many of you may recognize this slide from the county health rankings in Madison, Wisconsin, that Robert Wood Johnson Foundation has funded. And what this slide illustrates is that idea of the social determinants of health, that when we really want to talk about people's health, we have to think about broader concepts than just what happens clinically. And I think we're all aware of this now. It's certainly key to the concept of health equity, but that really the clinical care that most of us have done for our professional life is very important, but it only accounts for about 20% of health outcomes. The rest of what makes people healthy and not healthy is related to their physical environment and social and economic factors in their lives and their personal health behaviors. And this is really important to set up when we talk about health equity, because it really expands the realm of what we're looking at to say we need to look at clinical care and access to clinical care, but we also need to look at those social determinants. We need to look at where people live, work, play, and pray to see what other factors influence their health. So this is the CDC definition of health equity. There are many, but the idea is really giving people the opportunity or providing structures for the opportunity for people to attain their full health potential. So taking away barriers to ill health. And as we know, inequities in our society have been reflected in differences in things like length of life and rates of disease that have often differed by where in the country you live, by racial and ethnic background, and other social factors that we can begin to look at and address. Why is it important for nurses to think about health equity? Well, I have a couple of reasons, and I will refer back to them later. I think everyone in the healthcare system needs to be thinking about health equity. But for one thing, there are more nurses than anybody else. There are 4.3 million registered nurses nationwide. We are everywhere. So if you can make a change in nursing practice, you have the potential to really impact the healthcare system widely. Additionally, and you all also know this, we are the most trusted profession. I think it's the 19th year in a row that Gallup poll has said nurses are the most trusted profession. So people listen to us. People think that we have their best interests at heart and that they can trust us. Thirdly, we have the most holistic definition of practice of any of the health professions. Certainly other health professions are important and critical in thinking about health equity, but the current scope and standards of nursing practice just put out by the ANA defines nursing as the art and science of caring and focusing on the protection, promotion, and optimization of health and human functioning, prevention of illness and injury, facilitation of healing, and alleviation of suffering through compassionate presence. It talks about nursing as diagnosis and treatment of human responses to illness, and the important role of nurses as advocates in caring for individuals, families, groups, communities, and populations, in recognition of the connection of all humanity. So it's a beautiful definition. It's quite broad. It really encompasses people and communities and their health all across the healthcare system and all of those social determinants we've talked about. So we've set ourselves up as a profession and historically been kind of that utility infielder, to use a baseball metaphor, that that connecting, that hub of the spoke for healthcare that really looks at patients and communities across the life cycle, across the healthcare system, and in the fullness of all the things that make them healthy or ill. Other professions are more focused on specific areas of health, and impact health, we look at the whole person. And then lastly, besides the fact that nurses are ubiquitous, or large in number, we are ubiquitous. We are everywhere in the healthcare system. We serve in schools and in workplaces and in prisons and in home care. And then we're in the system itself in acute and ambulatory care, in the surgical units and in long-term care. So everywhere people go to look at their health and address health issues, nurses are there. So therefore, we have a huge opportunity to be the group that thinks about health equity. Why is engagement important in thinking about health equity? And I'm thinking of engagement very broadly as an ongoing process that assumes that anybody we work with, any stakeholders, patients, other healthcare providers, communities, will be involved in working together from the beginning to the end of the process. So whenever you work with patients or communities, engagement means they're involved from deciding what the problem is, to implementing solutions, to evaluating whether the solutions have worked. So integral involvement. Why is that important to health equity? Well, the more engaged we are with our patients and our communities, the more we have opportunities to understand those patients and communities. What are their values? What are their experiences? And what are their priorities? This understanding really helps to create more effective solutions. The more we understand the communities and people we work with, the more we can look at what are the most effective solutions to problems with their health and to improving their health. And in addition, if we're engaging meaningfully, it increases the likelihood that these solutions will be accepted and sustained. In your practice, I'm sure you've had experiences when you just haven't connected with patients for whatever reason, and the work doesn't go as well. It's not as easy to get what needs to be done to help improve their health. You've also probably had experiences when you've connected very well and you really have a good relationship with patients, and then it just seems to go more smoothly. They trust you, they tell you things, you're able to work with them, and you're able to get to better health outcomes. In addition, if we engage with people and communities, we improve their skills in problem solving. We help work them through how to address health problems, and we help to empower and educate people across backgrounds. So I want to start talking about patient engagement. Even though I said the topic was going to be community engagement, most nurses, focus their practice on one-on-one care. And so we need to think about how we engage with individuals and then kind of scale that up for those of us who work at community levels. There's a growing body of evidence that demonstrates that the more meaningfully we engage in patients, the better their outcomes are and the lower their costs are. And of course, as nurses, we're mostly concerned with those outcomes, but we really want to improve that engagement because it does seem to help show evidence that it helps their healthcare outcomes. How does engagement improve nursing practice? Well, I'm going to tell you a little bit about my background in this, and then we can kind of work through how it actually helped practice. I started as an acute care nurse, as many people do. I had a scholarship to pay off from a hospital that I had worked at. And while I was in that hospital, this is many, many years ago, people stayed a lot longer in the hospital. And I was frustrated by the fact that I was doing my best nursing care for people that were in our hospital, and I was in an acute cardiac step-down unit. So these were fairly sick people, and they would be with us for a long time, and I would do a lot of discharge teaching and getting them ready to leave, and they would discharge and they would come back in 2 or 3 weeks. And it was due to diabetes or chronic heart disease or any number of medical issues. But I kept thinking, what was happening that they weren't able to stay home? They seemed like they were ready. It seemed like that they should have been able to maintain on their own. And they certainly wanted to. So when I finished my year paying off my scholarship to the hospital that had been so gracious and helped me get through my undergraduate education, I went into home care. I thought I wanted to really see what was happening in home care. And that was my first introduction to what I've referred to as the social determinants of health. We weren't calling them that back then, but the idea that health was broader than just what happened in clinical setting. And it was an eye-opener for me. I don't know how many of you have had this experience, but I would tell patients in the hospital things like, you have chronic heart failure, stay away from canned food because of the salt, the sodium content in canned food. And then when I got into home care, I recognized that this particular woman was not able to get out of her house to shop, and her neighbors could only shop for her once a month. So guess what she was going to have a cabinet full of, which was what was going to last, which was canned food. Or I told a person not to climb stairs because they weren't stable on their feet and they lived in a third floor walk up, and that was the only way they could get out of their apartment. So I quickly realized that a lot of what I had been sending people home with instructions on was really well-intentioned, but naive and unrelated to their lives. And that I really needed to start to engage with people, think about what was happening in their life, their lived experience, and try to see if we could problem solve together. So maybe they wouldn't achieve all the things I had said I wanted them to achieve when I discharged them, but maybe we'd actually make some real progress because we'd worked on a plan together that was realistic. So engagement in that case helped me to increase the trust with patients because I was asking questions and listening to their experience. It helped to encourage us to have meaningful communication and helped me to see that patient as not just the person in 1028 bed B that I had admitted and taken away all their clothes and valuables and they were in my setting, but a whole person in their environment, their community, with their family. It helped me to identify social needs, to look at what was happening in the kitchen and in the refrigerator and what their family support was like, if they were safe at home, if they had social connections. It helped me to learn to collaborate in a mutually beneficial and respectful relationship. At least that was my goal, that we had to work together because I could see their lived experience and could see that some of my prescriptions for them were not realistic. And I hope it helped improve outcomes ultimately. So what are some methods of engaging patients? One of the ones that nurses are using now a lot for individuals is motivational interviewing. And motivational interviewing is a particularly collaborative style of communication that is really designed to strengthen personal motivation and to help your patient commit to a specific goal. And it suggests, motivational interviewing as a technique suggests that you ask a lot of open-ended questions. So instead of telling people things or saying, did you do this today, yes or no, say, what did you eat this morning? How was your sleep last night? To really ask open-ended questions to help people be able to reflect on their experience. And then to be affirming of what they respond instead of saying, oh, that's not what you should have done, to be affirming of things they've done that have been healthy and positive for them, to help them reflect on their health behaviors, and then to summarize at the end what you two have mutually agreed on. So we teach our students motivational interviewing now. There are other techniques, but this one seems to be particularly popular as a way of helping get you engaged with your patients. And just a little side note, during the COVID pandemic, like most of you, I have been trying to exercise and trying to let myself do something fun while I exercise to keep myself engaged. And one of the things I've been doing is watching the show called The Midwife. Don't know if many of you have seen that show, but the midwives, particularly in the early days in that, this is set in the late 50s, early 60s in East London with nurse midwives that are in the community. They are so affirming. And it really made me think about my practice. And it also made me think about how I would love a little somebody over my shoulder to be that affirming. They tell those laboring women over and over, you're doing wonderfully, sweetie. Just go, I can see the head, you're making progress. You are so good at this. And I kept thinking how positive that must be for patients when we're affirming. Another way of engaging with patients is the idea of self-management, helping people with self-management of chronic illnesses. I'm familiar with Lorig's model. Kate Lorig happens to be a nurse. There are other self-management frameworks out there where you really work with patients around problem solving, making decisions, resource utilization, how to partner with them, and then ultimately taking action. Lorig has done a lot of work with this and has tested this model out and shown that this type of disease self-management is really useful and brings patients to better outcomes, engages them in the process, brings them to better outcomes. I was fortunate enough to be part of a study a couple years ago at Rush with a physician colleague looking at the Lorig model of self-management with diabetes. And we used community health workers in our study. So the study purpose was to see if this self-management model, as implemented by community health workers, would actually help patients be able to lower their A1Cs. So we were in a Latino community. Community health workers were making visits every 2 weeks for a year, and then every month for a year. So a huge amount of visits, approximately 36 visits over 2 years. Most of our patients got somewhere between 20 and 30 because things came up. They couldn't get in every visit. And the community health workers were people from that community, spoke Spanish because a lot of our work was in Spanish. And they worked with patients on the basics of diabetes, kind of what was their goals, and were they checking their blood sugar every day, and were they getting exercise, and were they eating properly. But it was designed around self-management and engagement. So it was designed around working with the patients to see where they were at, what was important to them. The study was successful. We found that those patients seen by community health workers had statistically significant decreases in their A1C. We selected people for the study that had A1Cs that were higher than what we wanted. We're out of control in essence. And so very successful study. We were very happy with it. But one of the little side things was we had to record all of the visits of the community health workers with the clients, because NIH funded the study. And at the time for them, community health worker was a new concept, and they wanted some quality assurance. So they had us record all the visits. And we went back and we did an analysis of a small sampling of those recordings. We transcribed them and looked at them and did an analysis of themes. And we specifically looked at diabetes content. So when had the community health worker talked with using specific skills? And then we coded everything else that they talked about that was not diabetes content. And interestingly enough, small sample, not definitive, but what we found was the patients who did the best were the patients who only had about half of their visits related to diabetes. The other half was related to relationship building and trust building. And our hypothesis on that is that patients did the best when they really felt like this community health worker cared about them and listened and talked about their uncle and their sister's wedding and what happened with their kids in school last week, that set up a relationship that then set the stage for the work on diabetes. We'd have to test that out further, but it certainly seemed true in the data we looked at. And I think it says something about time and what it takes to get trust and truly engage with patients. How do we measure whether we're engaging with patients appropriately? Well, there's a lot of measures of this that are in the literature, and still more that are needed. We can measure whether the patients understand what we're trying to teach them about their disease and self-management. We can measure whether they're satisfied. Are they happy with the visits and the process we're going through? We can measure their sense of self-efficacy. Do they feel like they're capable of managing their heart disease or their diabetes? There's research that shows that you need to feel comfortable before you're actually able to successfully self-manage. We can measure the behaviors. For diabetes, for example, did they indeed start eating more appropriately or testing their blood sugar daily? And last, of course, we can measure the patient outcomes. The literature suggests that we need to find better measures of these things, but we have some ways of measuring whether our engagement is really happening and whether it's working. So here's a couple of quick recommendations for nurses for patient engagement. We need to work on our communication skills. I think a lot of times, particularly our students, they're very interested in the, can they manage lines and can they do all the physical assessment pieces, which are very important for nurses to do. But those softer skills, those communication skills, I think are equally important. Motivational interviewing, being able to listen to clients and hear what they say, the teach back method, making sure they understand what we've just conveyed to them, being culturally competent so that we can see the client within the context of their culture and what's important to them. And then there's system issues. If my hypothesis about our community health workers is true, time is important. The more time we can spend with patients. So can we look at our systems and see where we can maximize the time with people so that we're able to build trust and have them understand them and have them work with us? Language fluency. We need nurses that are more fluent in the languages of our patients. I speak a very bad second Spanish. We are seeing more students come in that are bilingual and trilingual, and I think we need to encourage that more in nursing so that we can work with people in their native language where they're most comfortable. We need to do continuing education. Not everything that nurses learn can be done in their basic nursing education, and not everything can be picked up on the job. So how can we make our continuing education meaningful to help us develop skills in patient engagement? And then we need more nursing research on how to do this engagement, what are the best methods, and what are the outcomes that we can expect. So now I promised you we talk about community engagement, and I'm going to, excuse me, take a little sip there. I'm going to tell you two stories about work I've done or work I'm aware of in community engagement. In case some of you don't work in communities, you may not be familiar with these. One is actually a Michigan, I think she's a Michigan native, Nancy Millio, who wrote the book 9226 Kercheval Street, The Storefront That Did Not Burn, back in 1970. If you're not familiar with this, it's really a short, fun read, and it might be something you might want to pick up and look at. Kercheval was a nurse in the VNA in Detroit in the 60s, and she was working with a largely maternal child health population in a fairly low-income African-American community. And she got a grant to open up a maternal child center, so a daycare basically. And she wanted this center to be someplace the community felt comfortable, and that they felt like they had some ownership, and that they really used and were just comfortable there. So she tried to get them involved in the development. So how should it look? What colors should it be painted? What should the children be fed for snacks and for lunchtime? How would children be disciplined if there was a need for discipline in the daycare center? And she describes in the book the challenges she had, first of all, for herself, trying not to take charge, but actually listen. And secondly, the community. They expected her to take charge. They almost wanted it in some way, and they didn't trust her when she kept saying she wanted, them to make these decisions. But she worked it out. They developed this center. They opened it up. It was successful. And the title of the book comes from the fact that in 1967, there were some serious race riots in Detroit based on some of the social inequities that we have as a society. There were some serious, riots is the best word I can come up with, but some serious social dislocations going on in Detroit. And the community that Nancy Millio practiced in was damaged seriously. There were storefronts that were burned down, and just a lot of damage left behind in the course of the interactions between police and community. And the daycare center was not. It had a big X marked on it. And Nancy Millio's point was that people did feel that they owned this, and that this was a place they wanted to protect, even in the midst of these social injustices that they were protesting. So they're henceforth the title. And I think what Nancy Millio's story tells us is a lot about developing trust and working with people, with communities, to develop problem-solving skills. And that when people feel that they own something, they really do stick with it and engage in it, and it has the potential for more meaningful outcomes. The second story, not as dramatic as Nancy Millio, is work that I was involved in the late 80s, early 90s in inner city Chicago. We called the overall project Primary Healthcare in Urban Communities. We came from a perspective of looking at women as the core to community health and to family health, because women then, and actually still now, are quite often the ones in the family that are responsible for deciding what food to put on the table, when people should go seek healthcare, how much activity people get, all of those kinds of things that make up health. So our project endeavored to train some women from the community as what we called community health advocates, and have them work in a team with a nurse in their community to go out, see what people thought were health issues that they were concerned about and wanted to work on, and actually develop some interventions to address these health issues. So we had two communities, one largely African-American on Chicago's South Side, and one that was largely Latino on Chicago's Northwest Side, and groups of about 5 or 6 health advocates. And they each had a nurse with them. And they did go out and do this. They did ask people questions. They did their own version of a health assessment. They developed some interventions, one around family violence and preventing family violence, and another around vacant lot cleanup to make the blocks safer for children and actually give people a place to play. This was a new model, and this was a new concepts for many people. There was nothing like this in the literature. So we were literally building this plane as we were flying it. And so I'm not sure that our evaluation was as robust as it could have been. We looked at things like how many people engaged with us, how many people did we work with. We did some informal methods of looking at trust. How are we building trust? And then we looked at sustainability, and the projects themselves didn't sustain, but we looked at the sustainability of the workers, our workers, because all the women we worked with had been chronically un or underemployed, hadn't worked, and had been on public assistance. And at the end of our 5 or 6 years of this initiative, they all had jobs doing similar kinds of work with federally qualified health centers, with local community groups, with the city health department, et cetera. So in those kinds of ways, we measured sustainability. But what I learned from it was the difficulty of building trust and of working with communities, the challenge, because of what had happened before. So when we first sent our workers out with the nurse to talk to people about health issues, the first thing people on the street said to us is, oh, who's getting their dissertation out of this? Whose study is this? Whose research is this? We said, really, why would you think it was a dissertation? And they said, because universities, not just the one I was at, but all universities, they come through here all the time. They've always got an idea. They're always going to work with us, and they end up, somebody gets a grant, and when the grant's gone, they're gone, and nothing has changed. And the people in the communities had become very cynical because this had happened to them over and over, where someone came through, promised to work with them, and then just left them high and dry. And I'm not criticizing the researchers too much. I think they were well intended, but very much around our schedule of funding cycles, et cetera, and not thinking about what they were doing to the community and what they were leaving behind in that community. So that over and over this cycle happened, and the communities were no better off. They were still in poverty, struggling with all the issues they were struggling with, but they just hosted universities periodically. So we tried to make deals with the community to say, we will always be honest with you. We will tell you what our resource situation is. We will tell you when we are not able to be here in the way we're here, or when things are changing, but we will also try to work with you to leave you some things that stay long beyond any work that we do with you, some changes that you wanted to see in this community that can be long lasting. So that was how I first got into the whole idea of community engagement. And this is the CDC's definition of community engagement, which is about working collaboratively with groups of people that are affiliated by geographic proximity to problem solve, to meaningfully engage and develop some solutions for people, and see if we can do things that improve their overall health and well-being. Most people see community engagement as a continuum. It's not just we either have it or we don't have it. It's you can start with basic community engagement, and then you can move to more sophisticated levels and levels that are better for the patients overall. And so the basic levels of community engagement are outreach and participation. Can we get people to come to our health fair, to our clinic, to our screening, to our COVID immunization vaccine clinic? So basic engagement is, will they participate? A slightly more meaningful way to look at that is, what about consultation? We're going to actually ask them, hey, where should we have this clinic? What are the best hours for your community, for people in this area? And then at the far end of the continuum is meaningful collaboration, where we talk about, it's the definition of engagement I gave earlier. We talk with people from the very beginning. We define problems together, we create solutions together, and then we implement them and evaluate them together, so that we're not coming in to do a problem that I'm interested in, but we're looking at something that is mutually of interest and that we all think needs to be worked on. So I found this concept of community engagement very interesting, and I was fortunate enough to be on a federal advisory committee during the Obama administration. So the Obama administration, as part of the Affordable Care Act, created something called the National Prevention Strategy. If you're not familiar with it and you're interested, Google it. It's not operating exactly, but we have taken a bit of national prevention strategy and put it into Healthy People 2030. But it was a way of looking at how we could all look at prevention and trying to keep people healthy from the get-go. And it gave roles, it gave evidence-based solutions, and it gave roles for prevention for churches and businesses and health departments and social service organizations and universities, that everybody had a role to play in basically achieving health equity and in helping prevent disease and promote health. And as in this role on the Federal Advisory Committee for the Prevention Strategy, I found a lot of organizations that were doing community work, but they really weren't engaging people at the grassroots level. They were working with schools and WIC centers and churches and community organizations, which was terrific, but they really weren't getting down to the level of residents in the community. So I was really interested in why was that and how could it be done differently? So I asked for a sabbatical after the work with the National Prevention Strategy was over. And I had a sabbatical in 2017 to look at community engagement. And so I decided to look at it by talking to community organization leaders to see how they did it. They were closest to the grassroots. So what did they think community engagement was? Was it important? How did they do it? What were the benefits to it? What were the challenges to it? And did they have any recommendations for other people? So I interviewed community leaders, and then I took this data and did an analysis of it to look at just those things I mentioned: methods, effectiveness, benefits, challenges, recommendations. My sample ended up being 22 leaders of community organizations. So that's who I got to agree to be interviewed by me. Mostly in the Midwest, but I did have some people from other places. I did a convenience sample where I asked for recommendations from people I knew, and they gave me some, and I asked those people, and I kind of snowballed up. And I ended up with asking about 50 people to participate, 50 organizations, and I got 22 that agreed to participate. Most of my interviews were done in person, but I did do some by phone, particularly for those that were national in scope. You can see on the slide that each organization had a specific target population that they were designed to work with. Most of them were geographic. They were designed to work with the state of Illinois or the city of Chicago or the west side of the city. But some were focused on a specific racial ethnic group. Some focused on the uninsured or those in poverty. Some focused on specific disease, people with specific diseases or conditions. Some were gender specific, usually focused on women. And then some were focused on working with immigrants. So when I asked them what their definition of community engagement was, they didn't have a specific definition. They said that it was very important, and they talked about it as important, but they didn't have a way of that they could point to say, this is what I mean by community engagement. They talked about it in terms of skill building, in terms of grassroots organizing, and in terms of advocacy. And I have a quote here from one respondent who said, community engagement is how we're able to make change and to change the structural issues we are facing, as well as the social determinants of health. So they didn't have a formal definition, but they did see it as really important. Then I asked them about methods. What methods did they use for community engagement? And you can see most of the responses, the largest number of responses I got were groups that said they used community health workers as their method. I have a quote here from one of the respondents who says, we've recruited people for peer counselor training who didn't even have a high school degree or a GED, but they are, first of all, very rooted in their own experience. They're often good advocates for themselves and for others. So they thought community health workers was a really good way of reaching out to people. Some people, respondents talked about outreach. Some talked about training. One respondent said, we've asked the community what trainings they're interested in, because unless it's very much about them and their priorities, they won't pay attention. We've said to them, what do you want to learn? This is all about you. Another set of groups talked about social marketing. And the last response I got for methods was something called community circles. And this was only from one group, but I want to mention it because I thought it was really interesting. Community circles was a method used by a group up in Maine. And they said what would happen is a problem would arise Patients, this was a group that ran a federally qualified health center, a clinic. Patients would mention a problem, or funders would mention it, or the government would identify a problem, and they would pull people together who had a stake in that problem. So it would be a group of patients, of government representatives, of providers, physicians, nurses, social workers, of community organizations interested in that problem. And they would bring them together every 6 weeks or so for dinner and discussion. And they said dinner was vital. You had to, if you wanted to participate in the group, you had to come to dinner, because dinner was the way you connected and built trust, was just breaking bread, sharing a meal together, and talking before you got to the business of the meeting. The meetings themselves didn't have an agenda. They let the meeting go with wherever the group wanted to take it. And they said they had to do that in order to really get these groups to be invested and to feel like they were being heard and they weren't being rushed along. And sometimes the groups would disband after a couple of months. They decided they didn't really have a common issue that they wanted to work on. But several of their groups met for a year or two and developed interventions for the community. In one case, there was a concern with people, families who had family members that had mental health issues, and how would they know when that condition was worsening, and how would they know how to get help? And they ended up developing a little palm card or refrigerator card out of their community circle. So they were strong believers in their community circle. They said they take time, but that they're very effective and they engage people. It's a method I would like to see them publish more, because I think the rest of us could learn from it. So I asked them about benefits. What are the benefits of community engagement? Why should we do this thing that's kind of hard to do? And you can see what their answers are here on the slide. When groups mentioned building community capacity, one group said to me, our mission literally says that we want to build power within the community, nonpartisan political power for the immigrant or refugee community. If you involve the community, then they actually feel that empowerment is where they actually see that something affects them. So I thought that was a pretty powerful statement. A group, 32%, talked about strengthening community ownership or strengthening voice. And the quote that illustrated this to me was, I truly do believe that people have an innate ability to find things that will engage them. And if we can get the community engaged in their own individual health and in community health, we'll have a much better success and outcome rate in healthcare. So I thought that was a really strong statement about community engagement. 14% of the groups talked about increasing community participation, just getting more people to come out. And then another 32% talked about building relationships. And here's a quote to illustrate that. Well, I think, we can do our surveys and we can do all that, but there's nothing that's going to replace when you ask people, you're often not going to hear the truth. You're going to hear what people think you want to hear because of fear of retribution. So we need to create relationships and safe spaces for people to really give feedback. So you can see some themes in here about trust and time and safe spaces. I asked them what were challenges to community engagement, and you can see there's a long list of challenges, and I'll just highlight a couple of them. Differing priorities was mentioned by almost half of the respondents. And the quote that illustrated this was really significant to me because it reminded me of my home care practice days. If you're worried about where you're sleeping at night, or if you're worried about gunshots in your neighborhood, it's really hard to be focusing on, helping your kids with homework or getting everybody to bed on time or doing the tons of things that we know will make a difference in terms of kids' outcomes down the road. But once your life has become stabilized and the other stuff is starting to settle, then maybe it's time to talk about the next level. And I found that in my work, that when people are having emergent life issues and you're trying to talk to them about something else, it's not going to go well because they can't see beyond the emergent life issues. And I think that's true for all of us. When you have something right in front of you that's emergent, that's what's going to take all your attention. Groups also talked about limited resources and how they needed to try to use those limited resources. And here's a quote that illustrates that. You're having to deal with people who may not be able to attend your event because they don't have childcare, etc. So you have to try to meet their needs too, at the same time that you need them to be professional and do a job and put in the community work. You can't throw money at the problem. You have to really be there as a mentor and a coach in some ways, but also help them problem solve their own lives. It's just really labor intensive. It's some of the hardest work I ever did. Groups also talked about the challenge of getting participation, of cultural differences, And then this one I thought was important: lack of structures to facilitate community engagement. And the quote on this says, so you bring in someone from the Latino community or from the African American community, and they're surrounded by, the traditional structure or, the power structure of privilege. And you think you're engaging the community, but you're only bringing them to the table. You're not making it safe for them to tell the truth. Which I think is a quote that speaks to that time and safety and how you build structures to make people feel safe and be able to engage. They also talked about lack of technology, lack of training, and then significantly, and I really liked this one too, trust, lack of trust. And the quote on that one says that it's not that I don't trust you, it's just the mistrust I have for all the other people that came before you. And that to me sounded a lot like my experience in Chicago with the groups telling us, groups have come and gone before and they never do anything. They just get their dissertation and move on. So when you come in and you're trying to engage with a community group and build trust, it's not just yourself, but it's also all the experiences they've had before you that may make them more or less likely to trust you. I asked the community groups representatives, how did they measure whether it worked? How do they know whether community engagement worked? And they gave me a bunch of answers here. You can see them on the slide. In participation, the quote that I thought exemplified this was, I think turnout would be what I would consider a measure of success. Why is there not a big turnout? Another group said, or 36% of the group said, individual or community health outcomes told them whether their engagement worked. And the quote on this says, we know it's working because we look at, for example, occupancy rates and tenure, how long somebody's been in an apartment. And what we found is the families stay almost 3 years. And 3 years doesn't sound like a lot, but in the city market for apartment complexes, people usually leave every 11 months. So the fact that people are staying 3 times longer means that they're satisfied generally with their experiences and their experience through sense of community and educational opportunities. So clearly that was a community project around housing, and they were finding people staying longer because they were satisfied. So that was how they measured success. People also talked about individual outcomes. And I have a quote that says, we were successful in receiving 1115 waiver money to make the program free for anyone living in the county. And we've been able to serve over 500 people a year. And we have hard data of folks losing 5% of their body fat, seeing their doctors, A1C lab comparisons, as well as the list of medications before and after. So clearly this was a community engagement project working on diabetes, and they actually had hard outcomes from the people that participated. Groups also talked about measuring success by process measures, by how many partnerships they were creating, by empowerment, by developing residents. And this is the last quote because I had lots of stories like this. Developing residents, this quote says, this person that is on our board now, she is like one of our success stories. When I met her, she was a Healthy Start consumer. That's how we got to her. So if you're familiar with Healthy Start, it's a funded program for families, for family health. So in this case, the example was the woman started out as needing services and ended up being able to serve on the board of directors. So another measure of success was developing those residents. Building bridges, outreach, job opportunities, these were all informal ways that these groups were able to measure their success. Then lastly, I asked them, what are your recommendations for other people doing community engagement? What would you suggest they do? And you can see here, they talk about developing people, collaboration, creating relationships, quality improvement, cultural competency, meeting community needs, and then one group each talked about using technology effectively, community voice, or building structures. And I want to highlight the relationships and developing people. The quote I have for relationships is a group that says, I've learned that in order to be successful with communities, you have to be transparent, you have to be truthful, you have to be sacrificial, you have to listen to the community's story, you have to listen to what's not being said, as well as what is being said, because there's a lot of trauma. And I think that's true for individuals as well, that you have to be transparent and truthful and listen to their story and listen to what's not being said as well. So I thought that was a good quote about building relationships. And then the quote for developing people. So the importance of developing people, 27% of the groups mentioned it. And the quote is, I think that's critical for any organization that wants actual grassroots involvement because it's not only a matter of getting the person affected by the issue involved, but it's also what tools and resources you are providing to that person. So I think that's significant, because it's like that, if you want to feed a man for a day, give them a fish. If you want to feed them for the rest of their life, teach them to fish. It's leaving tools behind. It's helping people develop in ways that they can then go on without you, so that the community can continue to improve no matter what the outsiders, the researchers, the health department, all of us that try to work in communities, no matter what we end up doing. So conclusions from the study, it's clear that while the definitions of community engagement varied and weren't very specific, there was great consensus on how important it was. Developing trust was mentioned over and over. So was time horizons. People kept saying, you need to put in the time. You need to be here for time. And a lot of our projects and our work in communities don't allow for that need for time. Developing skills, as I just finished saying, will sustain your efforts, so that even when you finish with the particular endeavor you're working on, if you've left skills in the community, your work will be sustained. Empowering individuals and communities helps with sustainability and trust. We need to develop structures. We can't just bring people to the table. Perhaps we need to help them learn to speak at that table, learn to find their voice, so that we're developing structures for community engagement. We need resources. Of course, in what place in healthcare don't we need resources? And then we really need to do further research on what are the best methods for engagement, and what are the most reliable outcomes, because a lot of the methods we've talked about in the respondents in my study, and a lot of the outcomes were very informal. They were just what they were using. They weren't specifically created to be long lasting and reproducible by other groups. So final thoughts for you all on this whole idea of engagement and its importance for health equity. I hope I made the case early on that nurses are suited for being the leaders in this area. Again, that doesn't diminish the contributions of others. In working at health equity and looking broadly at all the factors that impact health, we need social workers and physicians and teachers and business people. We need everybody, and everybody has a role to play to try to make this a more fair society and improve health outcomes for all. But nurses can really be front and center on this, because of all of the arguments I made at the beginning, because of how many of us there are, how common we are in the healthcare system, and our trust status, and our very holistic perspective. I also hope that I've made the case that engagement is important wherever you practice, whether you're practicing in the ER with individuals, or in the surgical center taking people in, or whether you're practicing in communities. I also tried to make the case that nurses should be leaders in this, as I said, in developing and testing new interventions. We have great ideas. Let's develop them a little bit. Let's test them out, collect some data on them, and if they work, then disseminate them and have our fellow nurses be able to build on our ideas. And then lastly, although I say nurses should be leaders, but we need other people, we need to refer and collaborate. So because I recognize that housing is important to health equity and health improvement, doesn't mean I have to be a housing expert. I'm a nurse. It does mean I have to know where the housing experts are and be able to help clients and communities get engaged with them. Chicago is having a real community violence problem right now. I don't have to be a violence expert, but I can work with the police. I can work with the violence interrupters. I can bring them together. So by saying that nurses need to lead in this doesn't mean we need to do everything. It means we need to look holistically at how how we're engaging with our stakeholder groups, and how we're moving them on the path towards health equity, and who else needs to be at that table. I want to leave you with two thoughts. I always leave my students with this one. Where did your patient or population come from, and where will they go after leaving your care? If there's nothing else you do in your practice, I hope we all do this. Understand where our patients and populations came from, what brought them to this stage of health or illness, and where are they going to go afterwards? So if we know what brought them there, we know what those factors are. And then when we discharge them from whatever our place in the care continuum is, make sure they have help at the next step. So if I'm the intensive care nurse, I don't need to check out their housing, but I need to connect them with somebody that can make sure that they're safely housed. And then my favorite Martin Luther King quote that you're all probably familiar with, that seems really relevant to this topic. Injustice in healthcare is the most shocking and inhumane form of inequality. And I thank you for your attention today and am open to questions.